Welcome to Pharmacology Insights, where we break down complex pharmacology into simple, easy-to-understand concepts. In May 2026, the US FDA approved a drug called Sonrotoclax, brand name Beqalzi, for a cancer called mantle cell lymphoma. It's the first drug of its kind, approved specifically for this disease, and the science behind it is worth understanding. Let's start with the cancer. Mantle cell lymphoma, or MCL, is a type of B-cell non-Hodgkin lymphoma. That means it starts in B cells, white blood cells that normally live in a region of the lymph node called the mantle zone. In MCL, those cells undergo a malignant change and begin multiplying without restraint. 3 things define this disease. First, it's rare. Only around 3,300 people are diagnosed in the United States each year, mostly men in their late 60s. Second, it's almost always caught late, after cancer has spread beyond the lymph nodes to the bone marrow, spleen, liver, and digestive tract. For the patient, this plays out as a cluster of symptoms that are hard to ignore. Lymph nodes swell painlessly at first, which is part of what makes MCL deceptive. As cancer cells infiltrate the bone marrow, normal blood production breaks down. Patients become anemic, bruise easily, and become vulnerable to bacterial and viral infections their weakened immune system can no longer control. The spleen and liver enlarge, causing abdominal discomfort and a sense of fullness after even small meals. The gut lining is frequently involved too, producing polyp-like growths that cause pain, diarrhea, and bleeding. Most patients also experience drenching night sweats, recurring fevers, and rapid unexplained weight loss. Stage 4 at diagnosis is the norm in MCL, not the exception. Third, and most critically, MCL is considered incurable with standard therapy. That standard approach, chemotherapy combined with targeted antibodies, sometimes followed by stem cell transplant, can control the disease initially. BTK inhibitors like ibrutinib and zanubrutinib became the go-to option at relapse, and offered real benefit. But most patients eventually progress through these too. And after a BTK inhibitor fails, options become scarce and response rates drop sharply. With each relapse, the treatment landscape narrows. For most patients, it is ultimately a question of how long treatment can hold the disease at bay, not whether it can be cured. That is exactly the problem Sonrotoclax was designed to solve. To understand how Sonrotoclax works, you need one concept: apoptosis. Apoptosis is programmed cell death, a cell's built-in self-destruct mechanism. It sounds drastic, but it's completely normal. Our bodies eliminate billions of old, damaged, or dangerous cells this way every day. In healthy cells, apoptosis is tightly controlled by a balance of proteins. On one side, pro-apoptotic proteins like BAX and BAC, which push the cell toward death. On the other, BCL2, which suppresses or blocks the pro-apoptotic proteins. BCL2 has a pocket on its surface, called the BH3 binding groove. In normal cell death, a pro-apoptotic protein fits its BH3 domain into that groove, disabling BCL2 and allowing apoptosis to proceed. In mantle cell lymphoma, cancer cells overproduce BCL2. The bodyguard is everywhere. The result? Cancer cells become resistant to dying. Chemotherapy tries to kill them, but BCL2 blocks the signal. The cells shrug it off. That's the vulnerability Sonrotoclax targets. Sonrotoclax belongs to a class called BH3 mimetics. And that name tells you exactly what the drug does. It's a small molecule that fits precisely into BCL2's groove and locks it shut, with high potency and selectivity. When Bax and BAC are freed from BCL2's grip, they migrate to the outer mitochondrial membrane. There, they oligomerize and punch holes in the mitochondrial outer membrane. A breach called MOMP, or mitochondrial outer membrane permeabilization. This releases cytochrome C and SMAC into the cytoplasm. Cytochrome C directly triggers the caspase cascade, while SMAC neutralizes the proteins that would otherwise block it. Together, they ensure the cell is systematically dismantled from within. The cancer cell dies the way it was always meant to. Now, there's already a BCL2 inhibitor on the market, venetoclax. Approved for chronic lymphocytic leukemia and acute myeloid leukemia. So, how does sonrotoclax compare? Sonrotoclax binds BCL2 with greater potency and selectivity. It also clears the body faster, with a shorter half-life and minimal accumulation. As we'll see, that has direct safety implications. Elegant mechanism aside, does it work in patients? The pivotal trial is a global, multi-center, single-arm, open-label phase 1-2 study. The patients were 103 adults with relapsed or refractory MCL, cancer that had returned or stopped responding to treatment. All had previously received an anti-CD20 therapy and a BTK inhibitor. So, these were heavily pretreated patients. Median age was 68. The overall response rate was 52%. So, more than half of patients showed meaningful tumor shrinkage. Responses came fast. A median of 1.9 months. And they lasted, for a median duration of 15.8 months. To put those numbers in context, these patients had already burned through multiple lines of therapy. A 52% response rate in this setting, with responses lasting well over a year, is clinically significant. On that basis, the FDA granted Sonrotoclax accelerated approval on May 13, 2026. It is now the first and only BCL2 inhibitor approved specifically for mantle cell lymphoma. No drug discussion is complete without safety. And here, one concern stands above the rest. Tumor lysis syndrome, or TLS. Kill a large number of cancer cells quickly, and they dump their contents into the bloodstream. Electrolytes flood the system, uric acid spikes, and the kidneys can struggle to cope. TLS can become a medical emergency. It can appear as early as 4 hours after the first dose, or at any point during dose escalation. This is why Sonrotoclax follows a 4-week ramp-up schedule. Starting low and stepping up to the target dose of 320 mg once daily. Higher-risk patients may need their first doses administered in a clinical setting. Standard precautions include adequate hydration, around 6 to 8 glasses of water daily, and prophylactic antihyperuricemic therapy. The shorter half-life and reduced accumulation of Sonrotoclax, compared to venetoclax, may make TLS more manageable, though this is still being studied. Other notable side effects include pneumonia, the most common serious adverse event, occurring in roughly 10% of patients, along with fatigue, edema, diarrhea, neutropenia, lymphopenia, rash, and musculoskeletal pain. One important caveat: this approval is accelerated, meaning it remains conditional on confirmatory phase 3 data. Researchers are also evaluating Sonrotoclax in combination with the BTK inhibitor, zanubrutinib, blocking cancer cell survival on 2 fronts simultaneously. And early signals in related blood cancers have been encouraging. Let's close with the essentials. Sonrotoclax is approved for relapsed or refractory mantle cell lymphoma after at least 2 prior lines of therapy, including a BTK inhibitor. It's a next-generation BCL2 inhibitor and BH3 mimetic. It binds BCL2, frees pro-apoptotic proteins, and restores the intrinsic apoptotic pathway in cancer cells. Compared to venetoclax, greater potency, shorter half-life, and less accumulation. In the pivotal trial, a 52% overall response rate, with responses lasting nearly 16 months, in heavily pretreated patients. The key safety concern is tumor lysis syndrome, which is managed with a 4-week dose ramp-up and hydration. What makes Sonrotoclax worth paying attention to goes beyond the numbers. This is not a drug that floods the body and hopes for the best. It identifies a single molecular mechanism cancer cells depend on for survival and dismantles it. That's the logic of targeted oncology, and Sonrotoclax is a sharp example of it working. And that's it for today's pharmacology video. If you enjoyed this video, please give it a thumbs up and subscribe to the channel for more pharmacology content.